about radium-223. I mean that Simca trial when that came out. That was 2013. It's been a long time that's been around. How do you use that? Do you use that in your treatment algorithm? There's some data that suggests that enzalutamide and radium have increased efficacy. What are your thoughts?
Yeah. With radium-223, I think, unfortunately, we are using it less and less. It's a 3-month survival benefit in general. But for the right patient that has symptomatic bone pain, I still think it has a good place.
Steve, where would you fit that in? I mean, sequencing becomes a tough thing, right? And we're all struggling with that. There's no right answer,
right.
And some of it's patient dependent, some of it's access dependent. How do you deal with that if someone's where would radium fit into your algorithm?
It would eventually, but I'll be honest, kind of what we were talking about before, visceral mets versus bone mets. Yeah. If they have mostly soft tissue disease with not as much in the way of bone disease, then we're going the route of chemotherapy in association with the other meds. If they're widely metastatic bone lesions, a lot of spinal issues, that'd be something that we'd consider, whether it be just radium by itself or in combination with bone protection mechanisms and all that kind of stuff. But a lot of it will depend on like a bone scan. I mean, is it going to light up like a Christmas tree, or is there just a couple of solitary mets? But that's where I would do it, is in widely metastatic bone disease.
So one of the things I've found, at least in my practice, is in the days when we did monotherapy, we started off with hormone therapy, and they progressed to metastatic CRPC, and they had greater than 6 bone mets. I was going toward radium, or we might do CYP-T. But with the age of doublet therapy now, we're pushing that relapse back, and I've found at least that their ECOG status may have declined as a result of waiting that long. What are your thoughts about that in terms of, do we have a lower window of opportunity to use those other agents?
Yeah, I agree. I think so. I mean, I know we've talked about it at our meetings, especially Provenge, that it's been, less for sure for me. And I'm newer to this system, to the ABCEC system. But I think, if they're failing the doublets, they're getting worse quicker, and then their PSA is rising. You just don't feel you can give the Provenge. Sometimes I'll involve the radiation oncologist too, and then even the medical oncologist, see how bad, if they have rule out anemia, this kind of stuff, because obviously if you're getting the bone drugs, it can affect their blood counts, and it just goes back to their fatigue. How fatigued are they? And, you warn them they might need a transfusion or something. If they're progressing through the doublet, you have to amp it up, but can they get to chemo? If they can't get chemo, you're kind of running out of,
Yeah, right. It's performance status. Bob, what are your thoughts? How do you handle that?
I agree. I mostly using it for palliation for pain for the most part. I think it works fairly well for the bone pain for bony disease. The CRPC window is getting smaller and smaller, and these folks stay in the castrate-sensitive space so long with all the therapies that we have now that you've got a small window to squeeze in some of these therapies that are only indicated for CRP castrate-resistant disease. So it is tough, and with it being a 6-month treatment in general, some people don't have even that long in that window. So it is tough to squeeze in, but I'm mostly using it for palliation from a pain standpoint because I think it works really well for them.
So in that undetectable PSA, when you've got them on doublet therapy and they're kind of cruising, are you doing imaging yearly? How often are you doing that, and how are you doing that?
I am doing yearly imaging. For guys that are undetectable, I'm still doing conventional imaging for fear of, doing a PSMA PET scan. That's going to be too expensive. May not be covered. We don't know how many of those insurance companies are going to pay for in a lifetime. I know that's loosening up with the advent of these radiopharmaceuticals. But typically conventional imaging every 12 months, cath scan, bone scan.
Yeah, all right. We haven't talked about PARP inhibitors. Are you using PARPs very often? And when do you fit them into your algorithm?
Yeah, so depending on, how successful we are doing our germline testing.
Yeah.
So trying to remember to utilize that from the beginning, identifying those patients and trying to find the right patient that can handle it. And again, it's not overwhelmed with the treatment from the beginning, I think is key with these patients. So trying to identify the ones that it makes sense for, I think is the biggest struggle.
Yeah, and then I assume then you'd be doing some somatic testing then as well at that time. Then do you prefer tissue, or do you prefer? I mean, we have wet biopsies with circulating cells versus getting some sort of either pathology from their biopsy, or if they're biopsy to met. What do you prefer to do in that situation?
I still prefer tissue over blood.
Yeah.
And newer tissue over old, if at all possible. So always weighing that benefit of, is the biopsy old? Do you have a new easy met to sample? Again, weighing that risk versus benefit for the patient.
See, one of the things I've kind of noticed is that PARP, and once you start getting into that realm, the side effects start to ramp up, right? It's a tougher drug to manage sometimes. What are your thoughts about management of side effects of PARP inhibitors? What have you seen? Have you worked with any of your medical oncology colleagues for treatment of anemia, or how do you manage that?
I mean, I'll be honest, I haven't had any patients use a PARP yet. As I said before, I'm kind of starting to ramp up the germline testing and then occasional somatic, but I haven't had a patient on it yet.
We were talking about that just a few minutes before we walked in here. What are your experiences with that?
Yeah, I think one of our navigators presented that I had the most experience with PARP inhibitors in our.
Is that good or bad?
Probably bad, but you do get a handle on it. There's some nuance to it for sure. They do have significant side effects. The nausea is one piece that can usually be handled, but the cytopenias and the bone marrow suppression and the anemias can be profound, and they can drop very quickly. So by using that, we've found you have to monitor them even more closely than the labels would suggest. So yeah, I'm typically doing it myself with our navigation team, following blood counts closely. I have a couple patients that have seen medical oncology, and they've assisted with some of those things. But for the most part, we've got a decent, pretty good protocol monitoring those and instituting iron supplements and dose reductions or, therapy holds to try to manage that. So
yeah, I think we're fortunate. We have a fairly strong navigation system, very strong navigation system, I should say. And I think really monitoring them closely is key. Brian, do you have any thoughts about that? Or do you have anybody on our PARP?
Yeah, I've had a couple, but it's been similar. One thing that was difficult a little bit, I guess, and the couple that I had is I had like a PSA kind of bounce. I didn't initially, and again, I don't have a lot of experience with it. So, and whether or not you're having to take them off their other agent, and I guess I'm still learning the nuances of that. It's like goes back to the sequencing then,
Sure.
and if they're failing their doublet, and they somehow come off something, their PSA goes up when they start the new drug. Sometimes they get discouraged on this new drug and then their PSA goes up. But I've had one patient in particular did pretty well once he went on it. Then it kind of PSA leveled and he tolerated, didn't get anemic, didn't need transfusions or anything. So just tracking the labs close and using the navigators.